Thyroid gland is a very important gland which is located in our neck, and it is responsible for regulating a large number of activities across the body. The thyroid gland develops from a down growth from foramen cecum, which is at the base of the tongue, and it travels down our neck to reach this midline position where it fuses with the second component to form the thyroid gland. Any abnormality in the movement of thyroid gland from the base of tongue to the throat can result in thyroid problem, and this is known as ectopic thyroid. The thyroid gland starts developing typically around 6 to 8 weeks of gestation in the fetus, and by around 15 weeks we will be able to produce enough thyroid. What it means is that at a very crucial time between the first 15 weeks of gestation, the fetus is not producing any thyroid hormone, and it is entirely dependent upon the mother's supply of thyroid hormone. The mother and the fetus are connected via the placenta, which is the conduit of various substances between the mother and the child. It also acts like a sieve to allow the passage of compounds which are only helpful for the baby and allowing not passage of compounds which may be harmful. TRH, the product of hypothalamus, can cross the placenta very easily, and T4 and T3 pass by around 40%. TSH cannot cross the placenta, and this is good because if that was allowed, mothers who had deficiency of thyroid will have a very high TSH. This will cross the placenta and result in excessive production of thyroid hormone in the babies. Antibodies stimulating the TSH receptor or blocking it can cross the placenta freely. So mothers who have problems of autoimmune thyroid disorder, both hypo and hyper, low and high thyroid, can result in transfer of these antibodies to the baby to cause transient deficiency or excess of thyroid, which makes thyroid assessment of neonates born to mothers who have either hypo or hyperthyroidism extremely important. Anti-thyroid drugs and thyroxine both can cross the placenta. The passage of thyroxine is good because that will ensure the good supply of thyroid to the babies, but the anti-thyroid drugs may block the production of thyroid hormone in the fetus, resulting in transient hypothyroidism which may manifest in the babies 40%. So in fetuses who are completely devoid of thyroid, this 40% thyroid is good enough to ensure that they have got good supply. However, if mother is deficient in thyroid hormone, if they are not given adequate treatment, the babies will get less amount of thyroid, resulting in adverse developmental effects of thyroid gland. The fetal metabolism is such that it does not need a large amount of thyroid hormones. Even 30 to 40% of adult levels are enough. The major role of fetal thyroid is the brain growth. So a good treatment of mothers who have hypothyroidism would ensure that the babies will have a good thyroid outcome in terms of the intellectual development. As the pregnancy progresses, the thyroid hormone synthesis increases, with a major increase happening after around 28 to 32 weeks, which keeps on progressing till term. Newborns who are born preterm would have less amount of thyroid hormones, and this predisposes these preterm individuals to thyroid problems which we need to really monitor and assess. The major needs of the fetus, like the warmth, the electrolytes, the fluids, the calcium, the glucose, everything is provided by the mother through the placenta. As soon as the baby is born, it has to face the adverse environment. So a baby who was really protected by the mother at a temperature in the womb of around 38 degrees suddenly comes out outside in the world, which the temperature may be 10 degrees, 15 degrees, 20 degrees depending upon the weather, and has a severe cold stress. So the first thing a baby has to do to survive is to ensure that it does not become very cold, because otherwise all its enzymatic activities will go off. And in this, what it does is a very unique thing. The fetus accumulates fat throughout the pregnancy, and as soon as they are born, they will start burning that fat, resulting in production of energy, and this non-shivering thermogenesis is a major contributor, so to speak, of the response to cold stress. And the most important mediator of this is the thyroid hormone. As soon as the baby is born, the hypothalamic thyrotropin releasing hormone has a huge surge, resulting in increase in pituitary TSH, thyroid stimulating hormone, resulting in an increase in thyroxine, and that ensures that the baby is able to survive that cold stress. What it also means is that there is a rapid rise in TSH, T4 and all the hormones which happens in the first week, and this may last for around 2 to 3 weeks, suggesting that we need to be very cautious in interpreting these levels. So using the cutoffs for older children or adults would not be appropriate in this period, and doing a test in the first 24 hours is going to give us very erroneous results. Therefore, neonatal screening for thyroid hormone should be done only after 72 hours of life, when the thyroid hormones are relatively stable, and we should use age specific cutoffs. Children who are admitted or are given some treatment like steroids or some drugs to increase blood pressure like dopamine would have effects in terms of their thyroid hormones, and this may result in a wrong interpretation of thyroid functions.